voudrais remercier la SRLF pour m'avoir invité ici à Paris. Je vais vous proposer cette présentation en anglais parce que je l'ai déjeuné quelques fois en anglais et ça me facilite un peu les choses quand même. Mais naturellement, si vous avez des questions, vous pouvez les poser en français après. J'ai pas de conflit d'intérêt. So when we look to the 80s, the aims of modern medicine was that health would be maintained a lot longer, morbidity would be compressed, and death would become peacefully. Now, when we look today, an average resident live longer, often healthy, but with some collateral damage. 80% die in hospitals or long-term facilities, 65% are non-ambulatory, and 40% are chronically impaired in the 6 months prior to death. Also, when you look whether death would become peacefully, 50% of patients who remain conscious at the end of life experience moderate to severe PIR at least in half of the time in the 3 days before death. 46% of DNR orders are written within 2 days before death. It was much too late. And 53% of the physicians know patients' DNR preferences. I would say only 53%. And it's not that these patients didn't see physicians. This is a recent study from 2007 from the BMG showing that 38% of the patients see 10 or more physicians, representing a median of 33 visits. And what is important for today is that 25% of the patients are admitted in the ICU in the 6 months preceding death. And this is increasing, at least in the States. When you look here in 2000, it was about 24%, and now it is increasing nearly to 30%. I can tell you that in Ghent, we take about 40% of the deaths of the hospital, of course, not of the country, but of the hospital. You have some hospitals in Germany up to 80%. And in New Zealand, it's about 17%. So there's a huge variability in whether we take patients at end of life in the ICU. Now, we know this already from the 90s. This is here in a study from Jean-Louis Vincent, where he asked to ICU physicians whether they admit patients with no hope of survival. And here in France, like you can see, well, 88% of the physicians say indeed that they admit patients with no hope of survival, while only 45% say that they should be admitted. Similarly, in a very, very nice study here from 2001 from Vetters, here they asked to physicians what they do when a patient requests for non-beneficial treatments. Well, 70% negotiate with and educate the patients. I would say only 70%. They try to convince their patients in about 33% of the cases. They communicate over time, 7%. Using family influences, 16%. And not offering futile treatment, only 30%. So we prefer to give a futile treatment than really to take a decision and to communicate with the relatives. So the first message not to forget is that ICU physicians frequently admit patients with poor expectations. Another problem is that currently today, of course, you have a lot of machines. We can keep these patients alive most of the time nearly as long as we want. So we ask here in this study, and it is published in the JAMA 2 years ago, we ask to healthcare providers on one day in a cross-sectional study whether indeed they had patients in their ICU where they say that the care was inappropriate. And indeed, 27% of physicians and nurses, this was no difference between physicians and nurses, found that the care was inappropriate for at least one of their patients on the day of the survey. And when we ask how often do similar situations occur in your ICU, well, 63% say yes, often. So it's really a culture. And to what extent are you confident that inappropriate care as an inpatient will be resolved? It was again 60%. So they do not believe that something will change. Now, this appropriateness of care, or inappropriateness of care, was at several levels, but more particularly, of course, at the disproportionate care level, and of course, too much care. We ask also in the opposite direction, too little. This was not so frequent. But also, distributive justice was important because they found that other patients would benefit more, those that are waiting in the emergency room, for instance. But also lack of participation in decision-making, persistent non-adherence of patients, inaccurate information to patients of relatives, or not good quality of care that they can provide in their ICU. So the second message is that ICU physicians and nurses are equally confronted with inappropriate and most often disproportionate care in their ICUs. And this has consequences. First, it has consequences, of course, for the patients. It is well known here in this study that aggressive care indeed is associated with a lower quality of life, and has also consequences for the relatives because it often complicates grief, increase regret, and these families also have more problems with major depressive disorders after the patient's time. This has also consequences for the healthcare provider. If you ask to physicians and nurses, and the physicians are in the third column, what gives you really moral distress? Well, the first one is follow the family's wishes to continue life support, even though not in the patient's best interests. Initiate life-saving actions that only prolong death. Continue to participate in care when no one will make the decision to pull the plug. And this was equal in between nurses and physicians, of course. It was less distressful in physicians because they have the power. So, of course, when this moral distress will accumulate, over time, you might have problems, of course, and will show many problems depending on your coping strategy. But if really it accumulates to your department, then you have indeed a problem. Now, whether it will accumulate or not depends, of course, first, whether the people that, or whether the individual that expressed or that feels moral distress is really aware of the situation, and I will come to that when I will talk about solution in my last 5 minutes of my presentation. Second, how that an individual cope with hierarchy, because it's the hierarchy that will also can change the situation. You will not be morally distressed if you can change the situation by yourself. If you have the power for it, you will do it. So it's at typical the hierarchical level when you are morally distressed. And fourth, you must have also a hierarchy that allows you to individuals to come to you and to give you feedback also about your department. So can you really create a safe climate in order that these people do not come morally distressed at a chronic level? Because when there is accumulation, there will give repetitive acute conflicts, post-traumatic stress disorder, whatever. It's only words, I think. It's moral distress at a chronic level. You can also put, for instance, alcohol. In England, after the barkeepers, it's the physicians, the best drinkers in England. But much worse, I think, it's chronic unexpressed conflicts, which is a culture in the department, with, like we say in French, a lot of non-dit. That, I think, is much worse, because it will really affect the inadequate judgment of people, and also will induce a poor quality of care. And this is exactly what we found also in the Appropriate study, and this is a sub-study that's not yet published, where we looked to the ethical climate and this perception of inappropriateness of care. And the worse the ethical climate, the higher the perception indeed of inappropriateness of care. Now, what you have to know is that only 1/3 was congruent with regard to one patient. So there you have really true pessimistic people thinking that it is inappropriate. But you have, of course, realistic people, and that's what we will do now in May of this year. In the disproportionate study, we will link this perception with the real outcome of the patient. And also, if you cannot work on your working climate, then you will have a problem, because all the people will simply leave your department. And as you can see, for instance, in Germany, in the hospitals, we made a survey, 42% has the intent to leave their job. And finally, it has also a cost for the society. I always say, if as a physician we would have to come to the market like a drug, then we would probably not be reimbursed, because in certain situations our number needed to treat would be much too high. So the third message is that disproportionate care has many consequences for patients, relatives, doctors, nurses, and society. So an essential question, of course, is why then do we continue? Let's first look to the healthcare providers at the bedside. This comes again from the Appropriate study. As you can see, it is polyfactorial: prognostic uncertainty, lack of consensus, no one takes the initiatives, and so on. But there is an essential difference between nurses and physicians. Physicians say, oh, it's prognostic uncertainty, while nurses say, no, it's no one that will take the initiative. And here you have even a consensus between nurses and physicians, and no action despite consensus. Or not a priority at all by the majority of the team. Also, polyfactorial at the communication issue. We think we are good communicators. Well, the nurses do not agree with that. And it's not only with the relationship to the nurses, but also to the family. And third, of course, we have sometimes families that is not ready to withdraw care, or that exerts pressure, and also referring physicians that ask to continue the care. Let's look at the management level. There's one nice Canadian study here, also who asked to the people at the management level why we continue disproportionate care. Well, the third was prognostic uncertainty also. They were clear-cut that prognostic uncertainty leads to overtreatment. But also that as physicians, we cannot accept they've perceived treatment failure, and that we have difficulties with stopping treatment started by others. And finally, again, communication issues. So that is what is called in management is a lack of leadership. That's, in essence, what the terminology tells us. And here also in this study, again, there was a difference between nurses and physicians concerning the prognostic uncertainty. Now, let's look at the perception of the family and relatives. Well, there also, again, they found that our communication is rather poor. For instance, here in this study, prognostic information was not provided in more than 30% of end-of-life decisions in the ICU. And only 2% of the discussions contain all the ingredients necessary for safe decision-making. And about 22 to 50% here in these two French studies of the relatives were not satisfied with the communication in the ICU. And often the relatives, what clinicians' expression wait and see said, well, it hides a delay in communication of honest and clear information for them. So the wait and see is not an appropriate way to do it. Or at least you have to explain it. While most surrogates of critically ill patients do not view withholding prognostic information as an acceptable way to maintain hope. So that's a really important information, I think, for us. So the last, do not forget, is disproportionate care is often continuous because of prognostic uncertainty and poor communication, or what is called in management terms, a lack of leadership. Now, let's look to what psychologists think about us. Well, the first lesson that we can learn from them is that decision-making is not a pure cognitive process. And you can simply ask you can simply be aware of that if you ask you this question to yourself. When does uncertainty resolve? When I ask this to the medical student, they say, well, when I have taken a decision. But even if you have taken a decision, you can still feel uncertain afterwards. That's not a problem. It keeps on and on. No. The answer is, at the moment you feel good with the decision you have made or will make, regardless of the decision. So if you choose for A or for B, that's not the problem. The problem is that you have to feel good with the decision you have made. So what is uncertainty then? Well, uncertainty is anticipated fear and concomitant emotions, shame, and so on, for the potential consequences of taking potentially wrong decisions. And I put potentials 2 times because, indeed, there can be potentially a consequence, and it can also potentially be wrong, but it's 2 times in the future and not in the present. You try to anticipate. Now, where did this fear come from? Of course, I will not explain you the Oedipus complex. You need at least 30 minutes for that, I think, and it's not the word forget it, it's about the dynamics that is important. So I will show you one slide for this, because it's important about leadership and to understand what is leadership. The Oedipus complex is, in a certain sense, daring to take a position into the world. It's what is called your internal GPS, emotional GPS. It's daring to discover the world as a child and also subsequently as an adult. This makes that you have to abandon the mother or what it, at unconscious level associated with it, security, affection. In order to affront the dangers of the real world, therefore you need curiosity. And 3, to learn to cope effectively with this danger, to this creativity. And the child will do that by acknowledging and naming emotions and bodily sensations. In a certain sense, there is, of course, a real world outside us, but we all perceive the real world in a different way. That's subjectivity. And we all perceive it through our body. So if you do not accept the outside world, in a certain sense, you do not accept your body. That's, in essence, what Lacan's theory wanted to tell us. And we will do that with the help of the other, the authority. It will structure it. And of course, if you have the help of the authority, because if you are afraid of authority, you will have 2 reasons to be afraid: to discover the world and being afraid of authority. And if you have this help, well, the imaginary is progressively structured closer to the real. This means that maybe you are afraid of something, but it's only through experience it together with somebody that helps you that you see that you do not have to be afraid anymore. In a certain sense, that's what the Oedipus complex tells us. So if you come back to the slide here about moral distress, well, there we have to take a positioning into the real. At the moment we have a morally distressing situation, what happens with us? Are we really aware of what is happening? Second, how do we cope with authority and how authority cope with us? Do they provide a safe climate? Do they agree also to have feedback about their behavior? Most of the time not. So let's look how you, maybe to your coping strategies in difficult situations. Suppose that you're confronted with a patient with a low life expectancy who is suffering. Then this can trigger a lot of emotions at that moment. The first one is fear. Fear because, in a certain sense, maybe you are confronted with your own death because it's a patient with similar age. Maybe sadness also, because you will be confronted maybe to someone that looks to your wife or to your brother or someone else. Anger because you do not control things. If this anger is directed toward yourself, it's guilt. And powerlessness, a combination of these 4. And there again, doped, if you think that you can solve doped of uncertainty purely cognitively, this means that you're not aware of what your body is telling you. Now, most of the time, it will be rather difficult to assess that at that moment. We know how feels fear in our body and sadness, but guilt, it's very difficult to feel that. The second reason is simply because all these emotions are clumped together. We feel discomfort, or what we call stress. And the third thing is that in a fraction of a second, we will go to our coping strategy. And you can choose either for the fight strategy, destroy it. You can do it physically, very subtly to these patients. For instance, you can increase the dose of morphine without his consent. Or you can intubate the patients without his consent. You want to destroy the situation. You kind of go also to your boss at that moment and verbally be fighting, if you want to do that. But we're pretty strong in what I call rumination. Is at that moment you drive by your car at home, and during your driving, you're telling yourself that the next time you will not do it like this, which will be better and better. At that moment, you change nothing. It's at the imaginary level. You change nothing at that moment. So you want to make a priority here. Or you can go to the fight or avoid. You can physically, of course, avoid to enter the room of your patient, or physically avoid to enter the office of your boss. You can enter the office but talk about the weather if you want, not about prognostic information. But we are pretty good in rationalization in medicine. This means that we will look to details. We will reduce the patients to a couple of details because we all have them under control. That's very easy. And I don't know whether you know that, but this have a special name in psychiatry. This is called fetishism. The fetishist is afraid of involving emotionally with the person. We are often afraid of involving emotionally with our patient. Now, don't be worried, it's only a minor perversity. And we need that, because at the moment your patient is unstable, you have to focus on details. That's clear cut. But once the patient is stabilized, you have again to zoom out and to look whether indeed it was appropriate. And I see often that we do not do that. And the problem at that moment is that you will shift from this guy on the left-hand side to the right-hand side. Because if you have this nice guy or the other one at your bed, the outcome will be similar at that moment, because the number needed to treat will be extremely high. So I always say I would like to have an expert at my bed when I have a mortality of less than 30%, of more than 30%, and less than 90%. Because if I have a mortality of less than 30%, the expert will ask investigations that are not really required. And above the 90%, for him, everything is possible. At the imaginary level, everything is possible. So I will move on now. So the problem, of course, if you have many of these people in your department and many of these, then you will have a lot of conflicts. This is often visible. We call them burnout, especially when they really express it. And here is much more subtle, and we call it normal. Now I can tell you that's, of course, most of the time the nurses, it's most of the time the doctors. Now, what is the solution? Well, I liked very much this article in Intensive Care Medicine, What's New, from Maite Garusto-Oregas and Andreas Valentin, is that we have indeed to evolve from denial, and we are really in denial, I think, for disproportionate care, to a culture of taking all our responsibility in what we do at our level. Most often we are also in this bureaucratic culture. When we put responsibility on the rules, that's very easy. It's not me, it's the rules. We really have to shift to that. So how then can we do that? How to improve leadership? Well, I think we have to start with ourselves. That's here Manfred Casdevries from INSEAD here in Paris, who say, well, people in mental hospitals are easy to understand because they suffer from extreme conditions. The mental health of senior executives is much more subtle. We all have shortcomings, and we have to look to our shortcomings. And maybe if we are in a leading position, start with ourselves. This means that first you should know what are your main coping strategies. Why do you use them? And this means that you will have to assess why that you do these strategies. And 3, what do you really want to achieve? That's also, of course, very important, because at that moment you will be able to do it and you will get less much frustration that you think. And if you're really interested to go more in depth, this is a very nice article in the JAMA from Meyer that clearly explains the steps of how you can do this. No, I'll skip this. I have a couple of slides, but we'll end in 2 minutes. So there's really the essentials for leadership is what we call self-awareness, the ability to recognize and understand your moods, emotions, and drives and their effect on others, the self-regulation, the ability to control and redirect impulses and moods, and so on. I hope you're motivated, but empathy, of course, and social skills. This means that you have to start with yourself. This will not be enough. You have to be to improve the ethical climate, like I show you from the Appropriate study. And an ethical climate is not only with verbs of language. I think you prefer to talk with your boss like he's looking like that rather than looking like this one. And you have, if you want to improve the ethical climate, and there also you have to involve nurses, for instance, in end-of-life decision, organize regular debriefings, and above all, again, focus on what is not acknowledged in your team, on the non-dit rather than what is no, and focus also on emotions or how people express something, not really at a rational level. So we will evolve not from such a system, but rather to such a system, indeed, to an organizational system like Maite tells us in her article, where we give a positive feedback, of course, within limits, and where we stimulate creativity and responsibility in each of us. So I would end here with my conclusion that I'll already show. ICU physicians frequently admit patients with poor expectations. They are equally confronted with disproportionate care. It has many consequences. There is a lot of prognostic uncertainty and poor communication. And if we want really to know what are the limits of care, well, they are not really technological, I think, today, but the limits lie in ourselves, and more particularly in our ability to cope with uncertainty and hence our feelings. We'll first have to explore our own uncertainty before being able to explore the uncertainty of the other. That's only at that moment that you will really know and understand people and relatives and patients. Only at that moment you will know whether the care is indeed appropriate or not. So I think that you, I hope, will agree with me that Descartes was wrong,